excuse me, for those of you who missed that at the beginning, we're talking about chest tubes today.
Does size matter?
Yes, does size matter? We're going to talk about the 4 main ED indications for doing chest tubes. Spontaneous or iatrogenic pneumothorax, which is not what the debate is about, but kind of informs where these questions come from. And then talking about traumatic hemothorax, and then again, touch a little at the end about tension pneumothorax, which is not totally what this conversation is about, but there's just something else, some other food for thought. I will be presenting on behalf of medical chest tubes, and Michel will be presenting on behalf of surgical chest tubes. So we'll start by defining the two. So when we're talking about a medical chest tube, we're talking about pigtail catheters. These are typically between 8.5 and 14 French. They can be as small as 5 French for pediatric, but most of the ones we use, are closer to 14 that we have stocked at County. And these are performed with a Seldinger technique.
And then when we say surgical chest tubes, or just chest tubes in general, we're going to be talking about the traditional surgical technique, much larger tube, generally anywhere from 16 to 40, but more commonly you're going to see from 20 to 32.
Yep. And a lot of what we're talking about, about the size of these is because we're thinking a lot of patient experience and kind of what these sizes mean for them if they're both as effective. So just to kind of give you an understanding, a 14 French tube is about the lumen is about the width of a pencil, as opposed to a 24 French chest tube is about the size of a candy cane, and then a 40 French chest tube is about the size of a AA battery. So that's the size of the lumen, not the outer bore, but of what would be entering the patient's pleural space. And we're going to start off with talking about spontaneous and iatrogenic pneumothorax. When we're talking about spontaneous, we're talking about primary spontaneous. That's what all of the literature is done in. So this is someone, with healthy lung parenchyma who pops a pneumothorax. This is not someone with like cystic fibrosis or has been in the ICU with COVID for a couple of weeks. And, this is the assumption of like an underlying relatively healthy lung that didn't cause the problem, which is why iatrogenic, so us, doing some sort of a line that causes a pneumo is lumped right into this topic, because you assume that it's not due to underlying lung parenchymal disease.
So before we go into all of the juicy EBM, what do the textbooks say? So our Bible of EM Tintinales in chapter 68 on pneumothorax talks about the indications for the different types. So generally small pneumothoraxes can be observed versus a simple needle aspiration versus a small pigtail. The larger they get, the more often they recommend using moderate to large size chest tubes. And then, of course, in the case of a tension pneumothorax, which is a medical emergency, immediate needle decompression followed by a moderate to large size chest tube.
So there was a study published in the New England Journal of Medicine to evaluate, in these spontaneous primary pneumothoraces, conservative treatment, with a conservative versus chest tube treatment in the ED. So this was a multi-center, non-inferiority randomized control trial that looked at actually like no chest tubes at all, just evaluation of observation of a patient with a pneumo versus a chest tube for the spontaneous pneumo. The patients that they included needed to have like a moderate to large pneumos. These are big lesions, and it was all in ages 14 to 50, and it had to be unilateral. So they separated these patients into 2 treatment groups. One was either observation for 4 hours, or one was with a chest X-ray. So the first group that they did, they would, the observation arm got a chest X-ray at time 0. Then they were observed for 4 hours. They got another chest X-ray. If it didn't worsen, they were allowed to go home. For the intervention group, at time 0, they got a chest X-ray. They placed a chest tube. And then at the 1 hour mark, they got a chest X-ray again and saw if the lung had re-expanded, they clamped the tube. They monitored for 3 hours with a clamped chest tube, and then at the 4-hour mark, pulled the chest tube out and sent the patient home. Treatment failure for either of these groups was if they needed, either to have the clamp reopened, or if they needed a chest tube placed, or if in the observation group, if the pneumo got bigger, and then they were admitted. The primary outcome for this was lung re-expansion at 8 weeks. And then they followed these patients for 12 months. They randomized 1,316 patients, 154 in the intervention of getting that chest tube at time 0, and 162 in the observation group. One of the major flaws of this study is 60 of these patients were lost to follow up or didn't make it for their visit at the 56th day, that 8-week mark. But of those who completed this case analysis, the re-expansion at 8-week occurred in 98.5% of those with the pigtail and 94.4% in those with conservative management. So the risk difference was only negative 4.1 percentage points, which was clinically significant for non-inferiority of conservative management versus observation. They went back into the sensitivity analysis after that assumed all of the missing data was treatment failure. And that the re-expansion at 8 weeks would have reoccurred in 93% of those with the pigtails, but actually only 82 in those with conservative management. And so the risk difference at this point was 11 percentage point, which they were saying, no longer shows the non-inferiority. So this is one of the big studies that kind of informs this conversation of being able to observe as opposed to even putting a pigtail in at all, for these spontaneous, again, non-traumatic, but spontaneous pneumothoraces.
And then just to play devil's advocate from the someone who's going to argue for a more intervention procedure, there's limitations. Number one being, of course, these were non-traumatic pneumothoraxes. There was a fairly large number of patients that were lost to follow-up that didn't get follow-up at the 8-week primary outcome mark. And then there's a bias in the reporting of resolution of pneumothorax. So they noted that it's possible that the radiologists who were comparing the follow-up x-rays to the initial x-ray, those that had a chest tube in and then had it out, those radiologists might be more biased to say that there was faster resolution or that there was more improved resolution. So you always have to keep that in mind.
And then to, again, just argue the other side of this, the adverse events associated in this study were pretty significant on the intervention arm. So 49 out of 154 of the intervention arm patients had adverse events, as opposed to only 16 out of 162 of the conservative management. And the most common adverse events were all really related to surgical site. So they had, pain at the surgical site, getting surgical emphysema, lung collapse after removing the chest tube, persistent cough, or then, above these some infections, which were on both sides, empyema, skin infections. So switching gears, to then an ED study that was published in the Annals. This was a network meta-analysis that was comparing spontaneous pneumothorax management in a network meta-analysis, which Michel is going to explain.
Yeah, so we've all read meta-analyses before, but we just wanted to point out there's a little bit difference between a network meta-analysis, which is taking a bunch of different studies over a long period of time and comparing the data between each of them against each other. So here's a kind of a little chart that helps visualize for me myself. This is kind of how I figured out what this all meant. So this study that they did, they took 12 different studies from between 1950 to 2019, and they looked at all the data. And basically what they were comparing was for needle aspiration versus small chest tube versus large chest tube. So in general, how they do it is they take all these different studies. So let's say on the bottom column here, we have data from the first study, RCT, which was A versus B, and the second RCT was B versus C. And what they do in a network meta-analysis is they take those data points and put them
Extrapolate,
against
yeah,
each other.
figures.
Yeah. And so you, during this process, they have 12 different studies. But if you were only looking at two, you would have A versus C data and B versus.
A versus B and B versus C,
Yeah.
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 Yeah, so they were able to include 12 papers in this study that had 781 participants, and it looked from 1950 to 2011, comparing RCTs of needle aspiration, narrow bore chest tube, which they define as less than 14 French, with or without a Heimlich valve, and large bore chest tubes, which was greater than or equal to 14 French. So these were the three kind of different arms that they lumped all into one network meta-analysis. And again, this is just for spontaneous pneumothorax, and found that there was no significant difference between the interventions for small versus large versus needle, small versus needle. But the analysis between interventions was significant between needle versus small and small versus large. I'm sorry, the safety between them was difference between small versus needle and needle versus small and small versus large. Small bore chest tubes had the highest likelihood of being the most successful, is with their conclusion from this. And needle aspiration was likely to be the safest.
That being said, some limitations were that these were non-emergent traumatic pneumo and hemothoraxes.
So we will move into kind of what the bulk of the debate is about for traumatic pneumo and hemothoraxes by starting with traumatic pneumos.
So in the traumatic pneumo category, we're going to just start off with looking back at our Tincinelli's textbook. So what do they say? So generally they say historically chest tubes between 24 and 32 French were recommended for simple pneumothoraxes, larger tube size for hemothoraxes. And they did quote a study, which I'll talk about a little bit later, which is what a lot of the surgical guidelines, which is what ATLS all quote, is this study by Inaba et al. That was done in California. And basically they compared tube sizes, and they, in that study, found that chest tubes between the 28 and 32 size were just as good as larger chest tubes for all cause pneumohemothorax.
In comparison, the surgical literature, especially in acute care surgery specifically, talks about the fact that now these smaller bore, these medical pigtails are favored over large bore because of the patient experience for ease of insertion and patient comfort for traumatic pneumothorax, although they do still suggest using a large bore chest tube for hemothorax, traumatic hemothorax. So this is not a study meant to inform practice. This is kind of to inform the conversation of where we are right now. So this was a survey that was sent out to the Eastern Association of Surgery of Trauma, and to kind of get information about what are the chest tubes that are being used right now in our trauma base. So they sent got responses from 739 trauma surgeons, or people part of the Eastern Association of Surgery of Trauma, which is not all trauma surgeons, but in this 2010 survey, and then gave a set of case questions where they asked these same these trauma vignettes over and over with these three different variations. The patient was young or old, so if they always made the patient either 25 or 70. If they had normal vital signs, or if they were hypotensive, so kind of suggesting this patient is unstable or stable. And then if they had a pneumothorax versus a hemothorax. Again, this was just to get an idea of what is being done in practice.
This is a busy table that kind of summarizes what the practice of the different providers was. And so generally the people that responded were trauma attendings and trauma residents or surgery residents. But if we see here on the table, 4 stable patients, generally for young and old patient categories, smaller sizes were more frequently used than larger sizes. For hemothorax, for same age groups, larger size tubes were used more commonly than smaller size tubes. And then in the unstable patient category, basically everyone put in bigger tubes.
Yes, yes, it did.
Okay. So this is a study that was done to assess small versus large size tubes. This was in the International Journal of the Care of the Injured. It was done in 2017. It's a retrospective study that looked at all patients with traumatic injuries requiring tube thoracostomy within the first 2 hours of arrival to the ED. So I like this study because it's patients that we are going to be seeing with emergent need for intervention. The second good thing about this study was that the procedures were done by a mixture of EM residents and surgery residents being supervised by attendings, mostly trauma attendings. So the primary outcome that this study was looking for was tube-related complications. Secondary outcomes including additional need for invasive procedures, such as additional chest tubes and need for thoracotomy. Patients with only pneumothoraxes were excluded, but it did include patients with traumatic hemopneumothoraxes and traumatic hemothoraxes. But basically, they found that the insertion of a smaller bore 20 to 22 French chest tube had no difference in efficacy of the drainage, the rate of complications, and the need for invasive procedures compared to larger tubes, 28 French in size. So it's a nice kind of small single center study at a trauma center in Japan with a higher rate of more blunt traumatic injuries. But that being said, it helps kind of guide this thought.
Yeah, and again, this is looking at kind of like the moderate versus large chest tubes that are all surgical chest tubes. The like 20 to 22 versus like the 28 up to 40. The Trauma and Acute Care Surgery Journal also looked at it, did a retrospective study that was published a few years ago. That was a retrospective chart review of trauma patients. So again, this was looking back at the data to kind of inform the questions, and the RCTs. But it was done out of a lot of the studies that I'm presenting are from this one center, University of Arizona in Banner, because they've been working on this. But so this is one of their first ones that they put out, looking at this retrospective chart review over the 2-year period of this level 1 trauma center out in the middle of Arizona. So they compared 14 French pigtail versus any other surgical size chest tube just looking back and kind of seeing what was used. They found 9,624 trauma patients, and of those, 94 were treated with a pigtail, and 386 were treated with a surgical chest tube. 94% of these tubes were placed for pneumothorax, which was really, again, their primary target of what they were looking at. So they analyzed this subset of data for the pneumothoraces. They found that there was no difference in the primary outcomes that they looked at. Mechanical ventilation use, the number of days of having a chest tube, insertion-related complications, the number of ventilator days, the number of days in the ICU, were all similar between the chest tube, the pigtail, 14 French pigtail versus any size surgical chest tube. There was a small difference in tube failure rate, which all of these studies kind of define as like needing another tube or another procedure, that's thrombolysis, or like an IR guided procedure. They found there was a slightly higher failure rate in pigtail catheters compared to surgical chest tubes, but there wasn't a statistical significance between the two. And kind of the conclusion from this paper, is that pigtails is safe and can probably be performed for these traumatic pneumothoraces in lieu of a surgical chest tube, but that a prospective study needs to be done to strengthen this argument. Oh, and I guess, one of the other major limitations of this study is that this one center, University of Arizona, has a lot more blunt trauma than penetrating trauma, which is not really our patient population the way we see chest traumas.
And then just going into this same paper a little bit, I wanted to bring out the tables that they included, because it's a little bit interesting, and it shows some of the limitations maybe of the study. So most importantly, in table 1, for indications of chest tube or the pigtail, you notice that more of the pigtails that were placed were only for pneumothoraxes. There were very few pigtails that were placed in any sort of emergent condition, very few that were placed for hemothorax, and a handful for hemopneumo. So it's a much smaller number of patients compared to a much larger number of patients who got kind of a more broad variety of indications for surgical chest tube. And then the complication table, the numbers aren't that drastically different. There's 3 incidences of complications, but the one that was the most probably drastic was that they did an anterior approach on one of the pigtails, and it ended up in the left subclavian, which ended up requiring the patient needing a blood transfusion and withdrawal of that pigtail, and then a reinsertion of a surgical chest tube. So just to note that they are safe by statistical analysis, but there are things that you need to think about in the locations that you're putting these tubes.
Sorry,
He says terrible.
study or slide?
Study.
Oh, Sinner is Dr. Sinner just pointed out this is a terrible study. Most of these are,
Yeah.
so brace yourself. So the same group of people out at the University of Arizona then did a randomized control trial. Although this one doesn't actually answer the question of which one is, if pigtail catheter is just as safe or, just as effective as a surgical chest tube. But what they said was, since this is all really being guided by patient experience, we don't want patients to be in more pain. What do the patients think of these? So let's do a randomized control trial comparing a pigtail versus surgical, and looking at, some pain severity indicators, and then subjective from the patient, and pain medication usage during their hospital stay. This randomized patients to either a 14 French pigtail or a 28 French chest tube who had a traumatic pneumo. They specifically, all of these studies exclude emergent placement. So this is a patient who you got the chest X-ray, you see that they have a pneumo, you have time to talk to them about it, you set up, you place this chest tube. This isn't the patient who comes in extremis, who you're like asking the trauma surgeon, do you mind if I put this pigtail in instead? Like, that's not what any of these studies looked at. But they looked at, their primary outcomes were tube site pain assessed by a numerical rating scale, and total pain medications that were used. It enrolled 40 patients and showed that pigtail catheters had a significantly lower mean tube site pain scores than those with a surgical chest tube. At baseline, right after insertion, as well as on days 1 and 2. But there were no differences in pain medication administration. The significance was, this is all the perception of the patient, which is not nothing. I can see Dr. Sinner like burrowing a hole through my head with his eyes right now. But it was pretty significant. They took these 1 to 10, 1 not so bad, 10 unbearable, I could never do this again sort of pain scales. And on baseline pigtail catheters, the patient said it was around a 3 versus surgical chest tube, which was a 7.7. At day 1, they said their pain was around a mean of 1.9 for a pigtail versus for a surgical chest tube, a 6.2. And then on day 2, patients had a mean of 2.1 on their pain scale, versus again for the surgical chest tube being 5.5. So these are patients had a very different, perspective of what was going on during this time. And so the conclusion that, was kind of extrapolated from this study by the authors, that for these simple, uncomplicated traumatic pneumos, there's reduced pain at the site of insertion, without their secondary outcomes that they looked at were, failure rates.
So the next slide is talking about conservative management of traumatic pneumothoraxes. So we talked about the NEJM article that touched on conservative management for spontaneous pneumothorax, but has anyone ever really looked into select indications of traumatic pneumothorax, simple pneumothorax, and not doing anything? So there's a couple of studies. A lot of them are out of South Africa, and you could probably guess why, because there's a lot of penetrating trauma there. One of the studies, the first one, was a study that they did at this one group, is a level 1 trauma center in South Africa, and they wanted to see, can conservative management be done. This study was no emergent unstable patients, no emergent need for tube thoracostomy. And it was all patients that had a CT imaging of the pneumothorax. And that was important because they could measure the size of the pneumo much more accurately than you can on a chest x-ray. And to be honest, most of these small pneumothoraxes probably would be very difficult to see on a chest x-ray. But they looked at pneumos in this study. All of them were less than 2 centimeters in size. The majority of the group, like about 75% of the patients, had less than 1 centimeter in size of pneumothorax. And they did it by measuring the distance between the pleura and the chest wall on CT imaging. So they took these patients and they managed them conservatively. And only 3% of patients in the total of 125% of patients that they studied required a chest tube placement. Everyone else was able to follow up and with no intervention per se. The next study, very similar. This study was trying to gauge what a good cutoff is for size of pneumothorax from a traumatic etiology would be the best for conservative management. And so they chose a cutoff size of less than 35 millimeters, which is super small. But in this study, they found that 89% of patients were successfully observed with no chest tube. 96% of that 89% all had pneumothoraxes less than 35 millimeters. So if you have a really small pneumothorax, maybe you don't have to do anything about it.
Switching gears to traumatic hemothorax, which I think is where a lot of the discussion for this really lies, because this is where we start thinking about what's actually making its way through the tube. How high does the pressure need to be? Is the tube going to get clotted off? Is it going to be able to evacuate all the blood that's needed? And so this is kind of the more nuanced piece of this talk for us to think about in our traumatic hemothorax.
So this is an article that's probably one of the most commonly cited articles that I found from all the surgical guidelines and surgical literature. It was a study that was done at LA County Level 1 Trauma Center with a good mix of penetrating and blunt trauma. They studied different tube sizes, and the question being is, can you use a smaller? Is smaller, or in this case, a moderate sized chest tube, just as good as a large sized chest tube? So they looked at patients who had gotten tube sizes between 28 and 32 versus 36 and 40. So it was a prospective observational study by chart review. It was done by surgery, tubes done by surgery residents and EM residents. In total, they had 353 chest tubes that were placed for a combination of about 168 and 167 tubes being moderate size versus large size. Out of that, 275 chest tubes were inserted for hemothorax, 144 tubes were moderate sized chest tubes, and 131 were large sized types of chest tubes. So it's a pretty good, even study done between the two etiologies. They also had data that looked at just straight pneumothoraxes and a combination pneumohemothorax. Basically, what they found that there was no statistical difference in complication rate, complications of pneumonia, retained hemothorax, increased rate of tube reinsertion, or the need for imaging guided chest tube placement or VATS between the two groups, which a lot of guidelines and surgical societies point to using smaller size tubes, 28 to 32 French, than the large size tubes.
How did they decide that?
This was a retrospective.
Yeah,
This was a chart review.
This is a law, it's really not prospective, right?
Yeah, because it was all.
This is a retrospective.
Yeah.
Study. So this is a law, right? The
Wait.
patients weren't randomized, right?
They.
Sorry, they were not randomized. I do think it was done prospectively,
Yeah.
but it wasn't randomized.
Was it really done prospectively?
I'll have to get back to you on that one.
It was done by chart review, right?
Yeah.
It's retrospective.
this
I don't
one.
remember, to be honest. I'll have to get back to you on that.
Okay.
It's done by chart. That's right.
Yeah.
Yeah.
This one, that one actually might have been, because this next study was a retrospective. Anyways, the next study basically looked at, can you use even smaller size tubes? And this one definitely was a retrospective observational study in a level 1 trauma center in Japan. They did the same kind of study. They wanted to look and see which patients, if they got smaller size tubes, 20 French tubes, had equivalent outcomes and for complication rates versus larger size tubes. So basically found that the tube complication rate was about 7.8%, which is lower than the kind of general complication rate that you see for larger size tubes. Really the biggest limitation of the study was it was just gathering data on complication rate and then comparing that data to what other studies have found. So there was no ever direct comparison, but they hypothesized that a smaller size tube had equal or less complication rate than large size tubes, and that they could be probably used in traumatic pneumothoraxes.
So this was a prospective study that was done again out of Banner at University of Arizona, conducted from 2008 to 2014 at this just single center level 1 trauma center, and looked at patients who had hemo and pneumothoraces, to look at the difference between placing a pigtail or a surgical chest tube. They enrolled 496 patients during this time, and their primary outcomes were initial drainage output in mLs, because I think one of the things we think about is that this small tube is just not going to bring enough blood out quickly enough. It looked at insertion related complications and then a failure rate. But again, like all these other studies are defined as needing a second tube, having retained hemothorax, needing a VATS or like intrapleural thrombolysis or an IR guided procedure to evacuate blood. Their secondary outcomes looked at total ventilator and ICU days, hospital length of stay, total tube days, and mortalities. They found that actually the only difference between the two, the pigtail and the surgical chest tube, is that pigtails had a higher output of blood, which they kind of extrapolated to. The pigtails don't limit the blood. We don't know why it put out more blood than a chest tube. And that there was one fewer day that the patients had a pigtail compared to a chest tube placed, but there was no significant difference between insertion complications, failure rate, or like total ventilator, ICU, hospital length of stay, or mortality. These patients were randomized, yeah. Oh, I'm sorry, I'm sorry, these were non-randomized. This was prospective non-randomized.
So maybe the patients who had larger hemothorax got bigger tubes.
It's possible, yeah, the percentage bring up that possibly that the patients who had larger hemothorax. So yeah, so for the limitation, the limitation of this was a single study, non-randomized control trial, and that for several of the failed pigtails, they got a surgical chest tube, but they were still put in the intention to treat, kind of in their statistical analysis. So again, this was like a question generating prospective, but non-randomized study. So then they decided to do a prospective randomized control trial, again, at the same center. They compared 14 French pigtails to 28 to 32 French chest tubes for management of traumatic hemothorax or a combination of hemo-pneumo. This one only enrolled 43 patients, and their primary outcome was failure rate. Again, defined by retained hemothorax, recurrent pneumo, requiring additional intervention. And their secondary outcomes were the initial drain output, the number of days the patient needed a tube. They had an insertion perception experience, another kind of like pain patient-centered score called the IPE, on a score of 1 to 5, 1 being that it was tolerable and that 5 was like it was the worst experience. The results showed that there was no difference in primary outcome for this small, prospective randomized control trial. There was no difference in failure rate for pigtail catheter versus 28 to 32 French chest tubes. And that the only significant difference in secondary outcomes was that they had a median, the patients with pigtail catheters had a slightly better pain score. Their IPE, this insertion perception experience, was around 1 point lower than the chest tube, surgical chest tube patients. One of the things to keep in mind, really for everything that I'm presenting, everything from the medical chest tube side, is this major limitation that, like, none of these are emergent. These patients are not in extremis. They don't have hemodynamic instability. They're not intubated. So we're excluding all of those patients every time that we talk about this. And then again, this patient population is mostly blunt trauma. And the sample size is 43 patients. It's very small. So then the same group expanded their study out to a multi-institution prospective randomized controlled trial comparing the 14 French pigtail catheter with a 28 to 32 French chest tube for traumatic hemothorax, collected over 5 years from 2015 to 2020. And it enrolled 119 patients. This was designed as a non-inferiority study that looked, again, the primary outcome of failure rate, again, defined as needing another tube or retained hemothorax. And their secondary outcomes were similar to the first paper: daily drainage output, days with tubes, ICU stay, hospital length of stay, insertion perception experience on that scale of 1 to 5, 1 being not that bad, 5 worst experience you can imagine. Their results showed there was, again, an increase in the median initial output of the pigtail catheter compared to the chest tube, which no one really knew what to make of that in either of these studies. But they also had a lower IPE, insertion perception experience, in the pigtail compared to the chest tube. There was no difference, though, in failure rate, which is, again, their primary outcome that they were looking at. No difference in number of days that patients needed tubes or ventilated days, ICU stays, or hospital length of stays. Again, this excluded patients who were in extremis. There was no one who was intubated. There was no one who was getting a crash tube. And this study had to actually be stopped early because of COVID. So they were able to reach their numbers with these 119 patients, as they saw traumatic injuries declining, because all we saw was COVID. That was when the study had to be stopped.
So next, we're just going to touch briefly on tension pneumothorax, which is, obviously the most emergent condition where you would ever need to put in a tube thoracostomy. So what do the surgical societies say? Basically, they all say what ATLS says. And in situations of tension pneumothorax, it's all about timing. So the first thing they always say is to needle decompress while you're preparing for your surgical chest tube. ATLS doesn't really comment so much on size, but they do recommend a moderate to large size chest tube to be used. And more often in these cases, you're going to be doing your finger thoracotomy as fast as you can until you can get an actual tube in your hand into the chest, but very non-specific. But again, a lot of the societies and ATLS quote that INABA study that looked at the 28 versus 32 French compared to the 36 versus 40 French tube.
So we really couldn't find any data on this. No one really designed studies around these like crashing tension pneumothorax patients. So Michel and I did what we do anytime we have a clinical question. We called Beta because he's our EMIM consultant for life. And so the first thing he said was, "Hey guys, great topic," which I appreciate. I also think it's a great topic. And he went on to kind of talk about his thought process of what it is you're doing in these emergent situations. So the key is emergent decompression. What's going to be the fastest thing that you can do for this patient to decompress them? And really pointed out one of the major concerns with placing a pigtail is that, in these emergent tubes, you're not doing this based on a chest x-ray. You're doing this right at the bedside. So you don't really know where your pneumo is. You don't know where, your air is accumulating. And you don't want to stick a needle introducer into the parenchyma, with a pigtail catheter, as opposed to when you're doing that, tube thoracostomy, you're sticking your finger in, you're feeling for the pleural line, that you're in the right place, that your tube is going to go, where you need it to be. Do a finger thoracostomy. And then also just, again, quick just quicker, and that kind of the hunch is the surgical approach is probably a bit faster.
He's very supportive.
Yeah, he was very supportive of it, of us, always, always. So in summary of our 4 topics that we went over for today, for spontaneous pneumothorax, it is reasonable to use a pigtail catheter over a surgical chest tube. For a traumatic pneumothorax, if these patients are stable, it is again reasonable to use the pigtail catheter. If they're unstable, there's really not data to support your decision to forego a surgical chest tube and be more conservative with a pigtail. And where we specifically see this being kind of important is one of the things that Michel ran into recently was, or saw observed recently, was the patient got upgraded in the size of chest tube because the eventuality is the patient's ending up on the trauma floor, and that's what trauma wants. And so these are just things to keep in mind, to maybe talk to your trauma consultants beforehand. If this is going to be safer for the patient, if it's going to be a better experience for them, and it is just as effective, have those conversations with trauma, again, for these stable traumatic pneumothoraces.
And then just to touch on traumatic hemothoraxes, for stable patients, again, it's reasonable to consider a shared decision-making between the patient, the trauma service, and the ED team. But then, of course, in looking at those studies that we looked at, they're all not great studies, but all of them, or most of them, were done in blunt trauma with very stable patients. And then pigtails not really studied in emergent situations for all of the reasons we kind of touched on, and so they wouldn't really often be considered for those emergent situations. And then again, unstable patients with hemodynamic instability or tension physiology, there's really no clear indication to use a pigtail, and so you would always go for your surgical technique. And then again, tension pneumothorax, not a lot of data because who's going to really study that? But you're going to do a finger thoracostomy. And those are our references.